So my topic for today is jet ventilation. Coming to the definition, it is the delivery of high velocity gases injected through a small diameter tube, opening into the airway connector, either manually given or by using a high pressure jet ventilator. The principle is it is based on Venturi principle, wherein the gas is insufflated through an active process and exhalation occurs through a passive process. There is delivery of high speed of gas, thus lowering of pressure occurs and causing of uh, entrainment of gases surround, from the room air due to Venturi effect of gas stream, leaving the nozzle further, enhancing the tidal volume and decreasing the oxygen concentration. There are two types of jet ventilation, high frequency and low frequency. Low frequency is usually via a hand-triggered device. Examples are Sanders injector and Manager 3. Its use is limited to short investigative procedures such as laryngoscopy or bronchoscopy. Also, it is used in the management of difficult airway or cannot intubate, cannot ventilate scenario via a cricothyrotomy cannula. The frequency used is 8 to 10 per minute. Mechanism mainly is bulk flow or convective ventilation, that is mass flow of gases in and out of lungs similar to the spontaneous respiration. High frequency jet ventilation is characterized by delivery of small tidal volumes of 1 to 3 ml per kg, which is less than the total dead space of that is the anatomical and equipment dead space from a high pressure jet at supraphysiological frequencies of 1 to 10 hertz, followed by passive expiration. This term was given by Klein and Smith. It requires a special equipment and technique familiarity is required. It is a form of time-cycled pressure-limited ventilation which is governed by driving pressure, inspiratory time, and frequency. Tidal volumes here used are smaller than the dead space, and therefore alternative mechanisms of gas exchanges are required, which are described hereby. Firstly, there is laminar flow, which is present in the small airways. The Reynolds number is low, and hence the air closest to the walls is having slow velocity than the center of the airway. The difference in the flow rate becomes exaggerated with each breath, producing spike with rapid inflow of the airway along the airway axis, and outflow at the margins remains slower. There is pendulum mechanism wherein there is redistribution of inspired gas from full fast filling units to slower filling units, thus augmenting the gas exchange. There is convective streaming or Taylor's dispersion that occurs as a result of the asymmetrical velocity profile of the inspired gas, wherein molecules in the central zones where axial velocities are higher diffuse to the lateral zones with lower axial velocities and hence enhances the gas mixing. Cardiogenic mixing, which has a lesser extent of effect, is due to the rhythmic pulsations of the heart, which causes agitation of the surrounding lung tissue and molecular diffusion. There is bulk flow, which contributes partially to the gas exchange, as the leading edge of the gas front may actually reach a number of proximal alveoli. Coming to the indications, indications can be broadly divided into two main categories. Firstly, the ones facilitating surgical access, and the second ones are to optimize the pulmonary function. The other classification is used in emergency procedures, elective procedures, and critical care. For emergency, it can be used as a transtracheal cannula as interim life-saving measure in cannot ventilate, cannot intubate scenarios. In elective procedures, it is used in the ENT surgeries as diagnostic diagnostic laryngoscopy, wherein it provides an unimpeded view of the larynx, immobility of the vocal cords, and complete control of airway and ventilation. It can be used in supraglottic, subglottic, and tracheal stenosis and tracheal reconstructive surgeries. Also, it is useful in case of laser surgeries. In case of thoracic surgeries, it is used in for one lung ventilation of the non-dependent lung, which is slightly distended, causing minimization of the shunt by increasing the mean airway pressures, aiding perfusion and allowing carbon dioxide removal without necessity of large volume excursions. Due to the decreased peak airway pressures and tidal volumes, it is one of the conservative treatment of choice in bronchopleural fistulas. In radiological suits, because of it provides a motionless field, it is used in radiologically guided procedures such as radiofrequency ablation of the liver tumors, where it minimizes breathing related liver motion, and radiofrequency ablation of the left atrium. In case of lithotripsy, there is elimination of diaphragmatic excursion and is ideal for use in extracorporeal shockwave lithotripsy as it reduces the urinary calculus movement. In critical care, it is well suited for lung protective ventilation strategies in patients who are having ARDS or ventilator associated lung injury. Coming to the three different approaches, there are three different approaches of jet ventilation. One is supraglottic, transtracheal, or subglottic. Discussing about the supraglottic approach, it is minimally invasive technique wherein jet ventilation is given above the level of vocal cord using a specified tubings. The main advantage is it is a completely tubeless surgical field. There is reliance on the surgeon to maintain ventilation. There is rapid increase in airway pressure. The peak airway pressures and end-tidal carbon dioxide concentrations cannot be calculated with this method. There is increase in the vocal cord movements due to the jet, and also there is risk of blowing of the debris into the airway. The peak and mean airway pressures increase linearly with increasing frequencies as the expiratory time is shortened, but the greatest increase in the airway pressures is seen in the supraglottic technique. Hence, supraglottic technique should be avoided in small diameter stenosis due to rapid increase in the airway pressures. Secondly, discussing about the transtracheal approach, it also provides a tubeless field and hence operating conditions are unhindered by the anesthetic equipment. Also, entrainment is minimal, allowing a consistent FiO2. It is contraindicated in tight stenosis. Coming to the subglottic approach, the rate of increase of airway pressure is reduced with this technique. The pressures remain atmospheric and pathway for exhaust gases is open throughout the ventilatory cycle. Hence, it reduces expiratory impedance and gas trapping. There is consistent delivered oxygen concentration since entrainment is minimal. Peak airway pressures and end-tidal monitoring is also possible with the subglottic technique. The only disadvantage is that it does not give a completely tubeless technique and hence may impede with the surgical access. Coming to the complications of high-frequency jet ventilation, firstly, due to the use of high-pressure gas source, there are chances of rapid increase in the airway pressures due to gas trapping and hence may lead to barotrauma. There is hyperinflation or inadvertent PEEP causing air trapping, causing pneumothorax, pneumomediastinum, pulmonary interstitial emphysema, and subcutaneous emphysema. Also, the gas trapping impairs cardiac output. Right ventricular end systolic volume shows a direct relationship with ventilatory frequency. As the intrathoracic pressure rises, venous return is reduced and right ventricular afterload is increased due to compression of the pulmonary vasculature, which can effectively cause complete loss of cardiac output, hence causing hypotension and right ventricular failure. It causes the gas exposure to the dry gas may lead to mucosal trauma, airway injury leading to necrotizing tracheobronchitis, atelectasis, loss of ciliated epithelium, mucosal inflammation, and excessive mucosa and airway plugging. Complications due to inadequate gas exchange or impaired ventilation could be hypoxia. There can be hypercapnia due to inadequate amplitude of ventilation, insufficient inspiratory time, and inadequate rate. There can be hypocarbia. Malposition of catheters can lead to gastric distension or rupture and dysrhythmias. Also, there can be airway soiling during jet ventilation. Coming to the advantages, are that it provides a motionless, quiet lung field for surgery. There is minimal movement of the lung tissue and mediastinum. There are the small tubes and catheters passed across the surgical field permit ventilation of the distal airway, thus bridging the defect and pathology and providing an unobstructed airway access with less interference with the surgical field. It can be used in laser surgeries. There is open breathing system, thus no need of tight air connections between the airway and the breathing system. It gives good exposure to the larynx. It can be manipulated by the surgeons during surgery. Physiological advantages are that hemodynamic compromise is less, the peak airway pressures are reduced, cardiac output can be augmented using ECG synchronization. Anesthetic advantages that it is a versatile, it has a versatility and hence is good in airway management. There is emergent transtracheal jet ventilation availability. Coming to the disadvantages, the cardiopulmonary assessment is difficult because the heart sounds and the breath sounds cannot be auscultated due to constant vibration and noise of the ventilator. Capnography cannot be ascertained. Carbon dioxide measurement is not accurate. Transcutaneous carbon dioxide measurement can be done, but the latency is there, and hence there is only local value is obtained and no global value of the carbon dioxide measurement can be obtained. For measurement of carbon dioxide, intermittent high frequency jet ventilation suspension needs to be done and have to reduce the frequency to less than 10 minutes. Efficiency of gas exchange is less predictable in certain conditions such as COPD and obesity. In morbidly obese patients, there is limitations due to airway collapse and difficulty in visualizing chest rise and fall. It cannot be used in airway stenosis, which is greater than 50% of the diameter. It has potential for lower airway soiling in case of ENT surgeries. The delivered FiO2 is multifactorial. There is potential risk of barotrauma. Contamination of the expired gas flow by the surface debris can happen. Anesthetic disadvantages includes inhalation anesthetic is impossible and impractical. Contamination of operating room air by the gases used. The end-tidal CO2 concentration calculation can only be done intermittently. High gas flows are required. There is need for humidification. Now coming to the equipments, jet ventilator catheters required for supraglottic technique employs some certain tubes and special catheters. And for the transtracheal and subglottic approaches, there are jet ventilation catheters. For subglottic catheters, examples are Hunsaker, Monjet, and laser jet catheters, which are double lumen catheters, in which the internal lumen is used for ventilation and the external lumen is used for end-tidal CO2 calculation as well as the pressure calculation. The transtracheal catheter example is Rabussin's jet ventilation catheter, which is available in 3 sizes for adults, children, and infants respectively. Coming to the jet ventilator machine, one of the examples is Mistral and Monsoon jet ventilator. It is an electrically powered solenoid cycle automated high frequency jet ventilator. The volume of each pulse is determined by setting the respiratory frequency, inspiratory-expiratory ratio, and driving pressure. Increasing the frequency or decreasing the driving pressure reduces the tidal volume, whilst increasing the inspiratory time or increasing the driving pressure has the opposite effect. An essential feature of the ventilator is an airway pressure alarm and automated cutoff when the airway pressure exceeds the set limit. The limit is set as the pause pressure, which is the pressure inside the airway and is measured from the tip of the jet ventilator catheter between each jet. The pause pressure approximates the mean airway pressure. Coming to the technique, the jet ventilator, once the airway is open and high frequency jet ventilation is started, the jet ventilator is attached to the central lumen of the catheter and the capnography and pressure tubing is connected to the monitoring lumen, both via Luer lock to prevent disconnection under pressure. Initial ventilator parameters are set. It is usually commenced at the frequency of 100 to 150 breaths per minute with FiO2 of 100. The driving pressure is usually kept 20 to 30 psi. The pause pressure is 24 centimeter of water. Peak airway inspiratory pressure is 28 centimeter of water. And the inspiratory time is kept to 1/3 of the respiratory cycle, that is 35%. Adequacy of ventilation is assessed. Thank you, sir.
Have you finished or you are?
Sir, I'm finished.
You started adequacy and then you stop, got bored by yourself. Okay. Very good. That was a very excellent presentation.
Thank you, sir.
I also prepared my presentation based on the same article from which you have taken all the